With that, I would like to introduce our speaker, Dr. Ortiz, who will be presenting to us tonight, NAMI Santa Fe. Dr. Ortiz, thank you very much.
Thank you so much. So I'm Javier Ortiz. I am a psychiatrist. I am a community psychiatrist. The identity of a community psychiatrist sometimes is not fully understood, but a community psychiatrist, the mission is to take care of people with serious mental illness outside of traditional institutions, like in the past will be the state hospitals. And really, another aspect is the delivery or the development of services to care for people with serious mental illness. I'm originally from Mexico. I've been here in the United States for around 6 years. And I just moved to New Mexico last year. It's been a little over a year now. And so when I was invited to this talk, I was asked to talk about bipolar disorder and schizophrenia. And so that's what I want to talk about. I hope that the material is not too complicated. I did take the freedom to think that the audience is gonna know or have some form of lived experience with the material, but I'm gonna try to be clear and have some definitions in case those are needed. I'm gonna share my screen. Okay. Let me see. Opa. Can you all see my screen? Is it?
Yes.
There we go. That's how I wanted to see. Okay. So I don't know if this is a CME. Probably there's no CME here, but I don't have any conflicts of interest. Really, all of my salary comes from the University of New Mexico, so I'm not affiliated with anybody in the industry, and I will talk a little bit about the medication in my presentation. So I start with a complex concept that is called carving nature at the joints. Carving nature at the joints is this concept of you have nature out there in the world, and you have at some point to divide nature, to come up with classifications. Sometimes it's very easy. You say you can easily distinguish between a cat and a dog. And so carving nature at the joints in that way, classifying nature that way is very easy. But when it comes to psychiatric disorders that have a very unique nature, this classification is very complex. And so because I was asked to talk about bipolar disorder and schizophrenia, I start with this idea that before there were two, there was only one. Before there were two diagnoses of bipolar disorder and schizophrenia as two separate entities, there was insanity or madness. And there was not all of these complex classifications that we psychiatrists use today. In the 1900s, there was this concept of the unitary psychosis, which was just all of the people that were living in the German hospitals, the state, what will be like the asylums, they will be there, and they will all be considered part of the psychosis spectrum. And there was this concept of bipolar disorder and schizophrenia had not emerged. At the time, at some point during that period of time, some of the patients in the asylum were diagnosed with having syphilis, and so there was this idea that maybe there was something that we could find specific to each disorder, and the brains might have specific abnormalities that it was just a matter of time for us to find them so that we can classify the diagnosis or the disorders based on the cause or the origin. And so in this image, we see Emil Kraepelin. Emil Kraepelin is thought to be the founder of modern psychiatry. And by doing very careful examinations of patients and following them for many years, he was very bold. He was very bold, and he said that he thought that there were not only one, that there were two different types of madness, or two different types of psychosis. And in this case, he at the time in the early 1900s, he decided to divide these patients with psychosis into the manic depressive insanity, which will become bipolar disorder, and dementia precox, which will eventually become schizophrenia. And so this tradition of dividing the people, most people with serious mental illness, in these two big categories dates back to these men 100 years ago. He did this classification mostly on what is these clinical cards that he had. This is an example in this image. You see an example of this card. And so by following them for a long time and seeing how they did across many years, he determined that those that had specifically a poor outcome, that is those that with time and with many episodes, they just continue to deteriorate, and he called it dementia precox because he thought that they will go and become demented. This is before the era of medications. He classified those that had bad outcomes, that did poorly, as having the dementia precox, and those that didn't, but still require a lot of support and had these recurrent intermittent episodes of psychosis, he classified them as the manic depressive insanity. This is a simplification of the work of Kraepelin, but around 50 to 60 years later, we get out of Germany and move to America, and there was a crisis. There was a crisis in the United States after we found out that even with this classification and this tradition of dividing these two disorders, when you put a patient in front of a psychiatrist and you show them a video, the same video to a psychiatrist, they will have different opinions about the diagnosis of the patient. They did this in a landmark study in which they gave the videos to American psychiatrists and to British psychiatrists, and they found out that people were not communicating well. We did not have the same understanding about what was what. And so the decision to standardize, to come up with this manual, the DSM, in WashU it was necessary. It was necessary to come up with a standardization of what makes schizophrenia and what makes bipolar. And so this American endeavor started, and eventually the DSM becomes a global manual that determines how mental illness are defined. And so I'm going to define briefly how we understand the concepts of schizophrenia, bipolar disorder, mania, and psychosis. So schizophrenia, per that manual, the DSM, since around the 70s, it really has changed very little. It's a chronic psychotic disorder, and I'm going to define psychosis, that is characterized by a few things, including delusional ideas, hallucinations, disorganized behavior, sometimes catatonic behavior, and what we also call negative symptoms. And bipolar disorder is also a chronic disorder, but it's a disorder that is episodic. It's a disorder that has phases. There is the manic phase that I will talk about, and the depressive phase. And the person suffering from the bipolar disorder is thought to fluctuate between the two throughout their lifetime. Mania is the affective state or the mood state that is characterized by high energy, very intense, excited emotions, poor decision making, risky behaviors, lack of need of sleep. And psychosis is very hard to define. But psychosis is when a person is suffering from a crisis of rational thinking and shared understanding. And so I just wanted to bring those concepts, and so that there's clarity when we talked about them. And so I'm gonna now, really the idea is to understand the complexity of this dichotomy, the dichotomy of Kraepelin that said bipolar disorder and schizophrenia are two different things. And you know, we have built all of this system and science on top of these assumptions, but I wanna talk about whether these assumptions are valid and what are the shared what things schizophrenia and bipolar disorder share and where they are different. And so I needed to show a little bit of my work. So I had a publication recently last year in which my question was, is it possible to predict based on their early life history who's gonna develop schizophrenia versus bipolar disorder? And so what I found out was that both patients, before they have schizophrenia or bipolar disorder, they have a lot of mental health problems as kids. And they go to the doctor a lot, and the doctors diagnose them with a lot of things. They diagnose them with depression. They also diagnose them with ADHD. They give them medications. The patients get hospitalized. But at least at this phase of the illness, schizophrenia and bipolar disorder seem to be more similar than different. There were a few different people that eventually develop schizophrenia tend to have a little bit more problems with intelligence or problems with academic performance, while people with bipolar disorder tend to have more anxiety. But both of them have, what was very clear is that most patients will have a lot of problems before the first episode. So here, the important thing to note is that at least before it starts, there's no way to distinguish between bipolar disorder and schizophrenia. So a lot of shared things here. Now, the age of onset for bipolar disorder and schizophrenia is almost at the same time. So again, this is just a very simple graphic, but it's the idea that these conditions started around the age of 20. So we have that they are similar in how they look before the first episode. They start at the same time. And what about when the first time that they get sick? And this is probably a source of controversy, and I'm very clear that this is my opinion. But on a first episode, sometimes it's also not feasible to distinguish if this condition is going to eventually become bipolar disorder or schizophrenia or neither. Sometimes there's people that after they have psychosis, they are very sick, and then they eventually recover and never need psychiatric help. But at least in the first episode, I don't think this illness has clearly shown if it's going to be bipolar or schizophrenia. So I say this because as we were discussing, I work with the early team in which we see a lot of people that are just starting, and sometimes there's this idea of wanting clarity of the diagnosis, and for us or for me, having a clear diagnosis in a first episode is not the most important thing. So we diagnose usually the person that is just starting, this 20-year-old person that comes in as having a non-specified psychosis, and only through following them for years, for 1 or 2 years, the diagnosis starts to declare itself. I have this graph here because really after a first episode, people can go anywhere, can go do very well or can do poorly, and then they do poorly and then do well. So it's really a matter of following them and understanding where are they gonna end up. I need to talk a little bit about early intervention. So at UNM, we have the early intervention program for all people in New Mexico. At least our mission is for all of the people in New Mexico, but currently we are only based in Albuquerque. To support them and their families when they are just getting sick for the first time, or at least they're having their first psychotic episode, because many times these patients have been sick for many years, but they have not been psychotic. The early intervention has been considered the best bet for a public healthcare system to prevent all of the costs associated with treating people with serious mental illness for a lifetime. So in a way, we are a preventive service that aims to reduce the burden of this problem for society, while also providing the individual with all of the support available. So we are always open in early, we are always open for new referrals. We aim to see patients very quickly, immediately after we get a phone call. We aim to try to get them to our clinic very quickly. And if they do qualify for our services, then they are able to receive all of these services, which will include a visit with a psychiatrist that will usually result in the recommendation for medications, psychotherapy, case management, supported employment and education, and family education. If there are, in this case, in the clinic, we take people that are thought to be on the bipolar spectrum, but also people with schizophrenia spectrum, and we try to tailor the service to their specific needs. Okay, so that's the first episode. Now, what about if schizophrenia and bipolar disorder differ in terms of what are the symptoms that the patient experience? So as we can see in this graph, we have schizophrenia that has predominantly psychosis, which was this crisis of rational thinking, negative symptoms, which are of these things that schizophrenia takes away from the person, the ability to experience emotions, socialize, express themselves, and also there's cognitive impairment coming with schizophrenia. Now, bipolar has similar features, but then it has mania. So so as we can see, they share symptoms, but then they also differ in certain areas. And then, while I haven't talked about this, then at some point, years after, in the 60s, given this problem of having so much overlap between schizophrenia and bipolar disorder, this new condition appeared in DSM as an overlap condition that shares features of both bipolar disorder and shares features of schizophrenia. And so the diagnosis of schizoaffective disorder appeared. And so in terms of utility, and I would really like to hear your opinion when we open this up, if it's, if there has been different opinions from your psychiatrist that says, well, now you have schizophrenia or then bipolar disorder, you go to a different psychiatrist, and it's because they are seeing them or focusing on different aspects of the patient that are presenting with unique symptoms. So overlap in almost everything that we have talked about with only certain differences. What about, is there a way, this is also another question that we get, is there a way for us, the psychiatrists, to do a test to help us detect if this person has schizophrenia or schizoaffective disorder or bipolar disorder? There has been so much money invested in this, and in the, what was it? I think it was late 90s, there was the decade of the brain, in which, there was so much money invested in the brain and brain sciences to try to figure these things out. And we just have not been able to use the technology, the MRIs, to help us detect schizophrenia or to find something that tells us that schizophrenia is there. What about genes? Genes also, there are certain genes that are associated with schizophrenia and bipolar disorder, both of them. So there's a lot of overlap in the genes that schizophrenia and bipolar disorder share. Now, genes are also not something that we test to distinguish someone that has schizophrenia or a serious mental illness versus someone that's healthy. What about if we do them like specific dedicated batteries of neuropsychological tests? We can find some difference between bipolar disorder and schizophrenia. Schizophrenia, as it was known 100 years ago as a dementing illness, an illness that affects cognition, people tend to perform poorly on psychological metrics, but still, these are measures that are not regularly used in clinic, and the diagnosis of schizophrenia or bipolar disorder usually still tends to be the clinical based on what the psychiatrist is assessing. There's other metrics, measures of electrical measures of the brain that have been tried, like the P300, but we just have not been successful at that despite billions of dollar investments. So Kraepelin, the psychiatrist, started to, even him at the time that he decided to make this distinction between bipolar disorder and schizophrenia, even him at the time started to say that maybe his decision to divide these people that have psychosis in two was that's not completely satisfactory. And so this is how I want you to think about bipolar disorder and schizophrenia as diagnoses that overlap a lot, thinking that they share a lot of features and there are some differences, but for the most part, they are similar. There are certain cases that, as in this graph, there are certain cases that are purely very classic bipolar cases, and there are classic schizophrenia cases, but that's the minority. And so for parents or people living with psychosis, sometimes there's a lot of frustration coming from this instability of the diagnosis, that they go to a different psychiatrist and there's instability of the diagnosis. But this is a very natural problem to have when these categories share so much. And so if, let's say, one validator for maybe they are two different conditions because we treat them differently, but in reality, schizophrenia and bipolar disorder are also treated very similar. Most treatments for schizophrenia work for bipolar disorder, at least for certain phases of bipolar disorder, specifically mania. But also for the depressed phases, many antipsychotics that are the first line treatment for bipolar depression. What seems to be specific is that mood stabilizers do seem to only work in bipolar disorder. Lithium does not seem to be helpful in schizophrenia, and valproic acid does not seem to be very helpful in schizophrenia either. And so there are, again, a lot of similarities in how we treat bipolar disorder, but some differences in schizophrenia, but also some differences. And so when I was starting, I was saying that the big important thing that made Emil Kraepelin distinguish schizophrenia and bipolar disorder was outcome. That is, how they do in life. And so there's this study that is a study that shows how many people, I think this is a Danish study, how many people are employed with schizophrenia and how many people are employed with bipolar disorder versus the whole population. Obviously, these two conditions, as in red, are people that are having disability pension. Obviously, these conditions compared to the general population, very disabling illnesses. But there does seem to be a trend that schizophrenia is more disabling. So here we do find that outcome seems to be something that the diagnosis does well. The diagnosis of schizophrenia predicts worse outcome than the diagnosis of bipolar disorder. But both of them remain very disabling. And also the other outcome that predicts is mortality. People with schizophrenia tend to die younger than people with bipolar disorder, and both tend to die younger than the general population that has no psychiatric problems. And this is consistent both across men and females. So for instance, in men is 57 men with schizophrenia in Denmark, they die at 57 on average, and men with bipolar disorder at 62, while the general population at 76. So again, this is something that the diagnosis also is able to predict a little bit well. And so they also asked me to talk a little bit about new innovations. So there are a few newer antipsychotics, including cariprazine. Cariprazine probably has been in the market for around 3 years. It is probably, it's better tolerated, especially in terms of the weight gain. As you all know, or many of you will know, these antipsychotics tend to have a high burden of weight gain. And so it's well tolerated in that way. And it seems to be very good for mood and for negative symptoms. So there's one study on negative symptoms and cariprazine, and it seems to be superior to others. And it also is approved for bipolar depression. So it's a good antipsychotic for someone that is having both psychosis and mood symptoms or a high burden of negative symptoms. And lumateperone is also one of the new ones. The advantage is really that it has very low risk of what we call the extrapyramidal side effects, which are all of these movement disorders associated with taking antipsychotics, tremor, restlessness, the tardive dyskinesia that some of you might be familiar with, that is abnormal movements of the mouth that might be permanent. So those are antipsychotics that are in the market that might be a little bit newer. I don't think it's a huge revolution, those two. What seems to be, hopefully, seems very hopeful, and if we follow the money, it seems that there was, as I show in the graph, the day that Karuna Therapeutics released their trial, the stock of Karuna Therapeutics went, I mean, I don't know how much. I mean, it seems, I think it went like, it got like 50% more on one day after they released the studies. And it's really the first true innovation in around 80 years since the development of the first antipsychotic. This will really be the first antipsychotic, if it's approved, that does not act on dopamine pathways as all antipsychotics do. The FDA is promising that they are going to give us a verdict in September. And so we'll see how that goes. The stock market was as excited that Bristol Myers, a big pharma, ended up buying the company. And so, you know, there's this possibility of some hope for people with schizophrenia, and most likely, as we have seen, KarXT might also have effects on bipolar disorder. And so I conclude by saying that we in psychiatry, we need to continue dividing schizophrenia and bipolar disorder. But this division might not necessarily be perfect. It is very practical for all psychiatrists to have this division, but it's not a perfect division, and not necessarily one that is perfectly natural, like, you know, easily dividing cats and dogs, as I was giving in my example. Bipolar disorder and schizophrenia are more alike than different. And while there are a few cases that are very classically or pure forms of bipolar disorder or schizophrenia, most of them are not, and the symptoms that they have overlap. However, what does seem to be true is that how severe psychiatrists tend to assess for severity, and if it's very severe, most likely the diagnosis is schizophrenia. And that's all I have.
Thank you very much, Dr. Ortiz, for your presentation. We have a few questions in the chat. I can read them to you, or you can tackle them yourself, however you'd like. And then we don't have any hands raised yet, so we'll see if we get any questions from the audience. But if you want to tackle the questions in the chat first, that would be fine.
So my father and brother were diagnosed with schizophrenia. My mother was diagnosed with bipolar disorder. My son was misdiagnosed with psychosis and later with autism. I'm wondering if there is some connection with those three. Yes, I did not talk about the connection with autism, but specifically schizophrenia and autism share a lot of features too. There is in our diagnostic manual, there is actually a specific note made for people with autism to make sure to avoid this problem that your son had, that was diagnosed with psychosis, but it was autism, is actually the last criteria of the diagnosis of schizophrenia, that if someone has a diagnosis of autism, there has to be very prominent delusions or hallucinations to make the diagnosis of schizophrenia. Are there any psychotherapy methods helpful for schizophrenia or bipolar disorder? Thanks. Most of the helpful in psychotherapeutic methods for schizophrenia will be part of the cognitive behavioral model, including CBT. There are specific variants of CBT for psychosis. For bipolar disorder, there's also some specific training for social rhythms and a specific training to maintain, given that they are so sensitive to alterations in their circadian rhythms, it's very important to train them to have a very structured routine while maintaining social connections. I'm gonna go with Betty Shover. You're muted.
Thank you again. I've heard people, in fact, I just spoke to somebody who has a mental illness, and she said, I'm diagnosed with bipolar and schizophrenia. Is that possible, or is that just two different doctors who had two different diagnoses based on what you know.
They are based on the model in the manual, they are exclusionary one or each other. You cannot have both of them.
Okay.
What I imagine happened was either there was instability of the diagnosis, that is someone said schizophrenia first and then bipolar, or the other way, or there were two different opinions. Then or there is this middle of the road diagnosis that is the overlap diagnosis,
It's effective.
the schizoaffective. So the idea of having it's a complex concept to understand, but the idea of having these two disorders is not that she has two disorders. It's just not possible. She's just one person that has psychotic experiences, and it's a chronic psychotic disorder that can be. Is it better to classify in schizophrenia or bipolar disorder? It really depends.
Okay.
And so yeah, I hope
you.
that's helpful.
Yeah, thank you. Yeah, that's what I kind of assumed, but I thought I'd ask the expert.
Terry?
Thank you, doctor. I really appreciate this. This speaks very much to my family experience. About 16 years ago was when my son was first diagnosed. And like anybody that goes through this, the diagnosis becomes fluid over time. He presented with psychotic symptoms, depression, mania, the whole ball of wax. And it was originally bipolar disorder with psychotic symptoms, depression, etc. I won't trouble you with the whole history of it. But when you said initially that the initial diagnosis isn't that important, it seems to me, based on our family experience and other people that I know of, important in that the medication that is prescribed is specific to the symptoms and or the diagnosis. And in those early days, let's treat everything. Let's do an antipsychotic. Let's do a mood stabilizer. Let's do an antidepressant. Let's throw the entire pharmacological pile at him. So you can't determine what works and what doesn't, is where we ended up. And I would kind of like your thoughts on that, because your comments and your graphs about the overlap of all these symptoms is very useful and speaks, as I said, to our family experience, and I'm sure many others. And I'm curious what your thoughts are in terms of medication intervention in light of this kind of still fluid diagnostic protocols.
Yeah. So at the first episode, I do believe that unless it's very clear and classic, the presentation of mania, if it's just psychosis, usually psychosis is also a little bit, the person is agitated and doesn't sleep well. And so I tend to prefer to maintain this code or this diagnosis that this is unspecified. That is, I'm saying it's not declared yet, but we need to treat it. And as I shared on one of the slides, is antipsychotics are useful for both people with bipolar disorder and schizophrenia and schizoaffective disorder if it's the middle of the road. So the idea of having, the idea of an early intervention program is one of the goals is to have minimal pharmacological interventions, that is very few medicines, one or two, and at very low doses because they do respond. Sometimes what happens is the behaviors are very problematic, and psychiatrists are prompted to manage behaviors and might not give it enough time for the antipsychotics that usually take, while they start working early, they take full effect, or most of the effect happens in the first month. It's not like antidepressants that they take a month to start working. And antipsychotics work early, but slowly and gradually. And so sometimes what happens is that there's no patience, and there's also urgency to manage the behaviors if the patients are being dangerous. And so the idea of these early intervention clinics is to hopefully avoid this type of bad situations that happen. These early intervention clinics are relatively new in the United States. And so that hopefully people get a good start in all of these adverse circumstances at the beginning when the family is just trying to get a sense of what's going on does not happen.
Fair. Thank you.
Rose, CR Rose.
Hi, thank you. Yes, and thank you again for doing this and all the people participating. It's wonderful. So I am a relative of a young man with diagnosed with schizophrenia, and they're 34-ish years old, and just I think entering as a ward of the state.
Okay.
So appreciate the early intervention stuff. He's in Texas. Not much for him there. Would check himself into rehab, I guess. I don't know. They had like these rehab clinics when he knew that he was getting worse. And I think because he wouldn't take medication, they told him he could not go back anymore.
Okay.
So here we are. So that's the end of that. Very strange. I'll just get to there's so many questions, but you had just two. I think I'll focus on the early the biomarkers, the gene overlap, the psychological, the physiological, that chart that you showed us with, you know, that nothing was successful. I want to make sure I'm clear on this. So a lot of money was put into all these different types of tests, family
Yeah.
testing, see who's got it, et cetera, and they came up with nothing. Is that
So
what I'm
we-
hearing here? Or
So
they're just
so
not there yet?
so I'm blanking on the name. But he was the director of the NIMH for, I mean, probably like 10 years ago. And so there was all of this. I mean, there was really a lot of investment, and we got a lot of data, and we know a lot more than we knew 60 years ago. And thank you for this clarifying. However, for me as a clinician and for you as a family, the science has not translated yet to clinical practice for the most part. So it might be that some of the science has permeated and, you know, has allowed us to deal better cares, but really where the innovation has happened in management of serious mental illnesses in service delivery and not in fancy interventions.
So yes, so that's the reason why I asked that, is because maybe you've seen on public television, Dr. Amen has done a lot with CAT scans of brains and, you know, using nutrition, et cetera, which is
Yes.
which are always impossible for my nephew. So that was one thing. And then also Dr. Ben Lynch had a Dirty Genes book where he listed 10 different biochemical problems that can arise, like not processing folic acid or folate, whatever, or the different
So-
things like that. And I wanted to make sure that's so these are the things that you're talking about, right?
Yeah, so yes, those are the things. So Dr. Amen, you know, big psychiatrist with, you know, a huge following, but very controversial within mainstream science, like academic psychiatry.
But all those scans didn't come up with a lot of
All of
things.
those scans, you know, there's this idea when people start showing brains in social media with all of these fancy lights, everybody gets very excited, but really for treatment intervention, there's not much that has changed. And you know, I will invite you to read other like opinions of other psychiatrists of Dr. Amen.
Yes, I'm sure there are.
And for the genes, the folate, specifically you mentioned the folate genotype has been studied, but specifically for depression. So it's called the MHHT gene. The genotype has been studied specifically to predict response to folate supplementation in depression, and that's true that there's some evidence for that, but not for for the disorders that we're talking here.
I didn't mean it. I was just using that example, but thank you for clarifying that. And have you come across any correlation with Crohn's disease? Maybe
Most inflammatory conditions are associated with this type of illness. I don't know specifically the Crohn's disease, but migraines has been associated with schizophrenia, asthma. We're actually about to publish an asthma bipolar disorder association. So everything that tends to create inflammation in the body, like inflammatory bowel disease, such as Crohn's disease or ulcerative colitis, tend to be associated with just, this type of serious mental illness.
Thank you. Thank you so much.
Jane?
Thank you so much for the talk tonight. It's been really interesting. I have a son who has a schizoaffective disorder, bipolar type diagnosis, which I don't really understand, although I've always thought by just watching him that yes, the two, bipolar and schizophrenia, are very much overlapping anyway, from what I can tell. But I had put in questions previous to the talk that I wrote in before, and the science is all very interesting, and we have a huge family history of autism, and I have another son with ADHD. So the gene things are interesting to me too. And what you just said about asthma and migraines struck a note. But what I was asking was maybe something a little different than what you're sort of focusing on tonight. Is we have not a good relationship with my son. He lives at the other end of the country, and I can see his misery, but he has a lot of anger, and generally directed at the mother and the father, which I'm sure you see that. So my question is, how do you continue to support your loved one when they sort of treat you like you need to go away and leave them alone?
Yes, that is. I think there's a few other similar questions on the chat. The complex I mean, there's really, just to be brief, there's really, what I would recommend is to read Javier Amador's work. Yeah, so that really is probably the person that can guide you through the LEAP method, and listening and empathizing and accepting. But it's a challenge. It's a challenge that as a psychiatrist, sometimes it's just I'm just a witness seeing these illnesses destroy lives, and I also sometimes the anger is directed to me, and I empathize with the feeling of powerlessness. So I don't have a clear, a clear recipe to how to solve this complex problem.
Yeah. Well, I appreciate it. Thank you.
Colleen?
Yes, thank you for your presentation. And I was going to ask something similar about my daughter, who's 34, who was diagnosed with schizoaffective disorder along with alcohol and substance addiction, and she is homeless, and she does not accept that she presented herself with acute psychotic symptoms back in the fall to an emergency room. She doesn't accept the diagnosis, and so how do I where do I stand in this?
Yes.
I need to accept something to understand her position, but also she has agency. So
She has, yes. Yes. I mean, it's really very similar to the previous question, which really is, I will always probably direct these type of questions to the work of Javier Amador, and Bess, who is the program manager of Early, has kindly put the link of his institute. I also want to just make a comment on all of these legal interventions that we have, that also are not very successful. That here in New Mexico, I trained in Minnesota. Mostly Minnesota has a little bit more, the psychiatrist has a little bit more legal interventions that they can use the legal system to control the behavior of the other. But here in New Mexico, we have the certificate for evaluation. That is, the psychiatrist can petition the law enforcement to seek someone if we think that they are at risk for themselves or others. But then after that, there's really no other, other measure that can keep the person accountable. Now, the question that I've been trying to answer, and I'm trying to do some work, is if we have measures in the outpatient setting to keep patients accountable via the legal system, will those be helpful? And it seems to me, I mean, and there's some evidence that they also, even legal interventions also are not very helpful in supporting patients with this, with this lack of insight, problematic behavior, substance use. And so it's still a big challenge for the field and for society, for me as part of the medical field, but also as a community and as a society. How can we support these people?
Thank you.
Casey?
I was just wondering if there were any non-medication interventions that help. My mania is pretty well managed, but my depression is not. I've tried TMS. I tried to have ECT for a second time last August, and the muscle relaxer that they used sent me into mania. So I couldn't continue that course. Is there any non-medication things? Because I've been on almost everything.
Yes, I mean, you've tried probably the two other neurostimulation strategies, that is TMS, that seems to be well, we just recently had good success with one patient, and ECT. As the two big interventions that a psychiatry, when you go to meet your psychiatrist, will recommend, those are probably those. In terms of the other ones, really for bipolar disorder, and for major depression, high intensity aerobic exercise seem to have some benefits, and really taking good care of your sleep cycles. I think those two things, of you can get your heart rate high and sleep well, those two things seem to support. But the way that I am trained and the way that I understand the bipolar illness, most likely it needs a little bit of medication, and lithium seems to be the one that at least one psychiatrist that I follow seems to be the one that is the only one that really targets the disease as a whole, and not just targets the symptoms.
Yeah, I've been on, I don't know, 30 medications, and I'm on 7 now, and
Yeah.
it's okay. It's livable, but I mean, I'm not like suicidal, but I haven't had luck with medication.
Yeah. It's a challenge. I think there's a little bit of hope coming with this other new medicine that I was talking about, although it's just right now being studied for schizophrenia. you know, I mostly, most of my expertise is in schizophrenia, so there might be some other prospects coming on for bipolar disorder. Always, like, if you feel like very motivated, looking for clinical trials is always a good option.
Yes, I looked into
Yeah.
the VNS surgery,
Okay.
and you just can't get it in New Mexico.
You cannot get it in Mexico, yeah.
Yeah, they had I think it's called the Recover study, but it's nowhere near here. So thank you.
I'm sorry, Casey, for this. Thank you. Okay, I
Well,
think I have a few to go. There's a few questions in the chat. Yeah, go ahead.
I think most of the questions in the chat were just comments on things that have been made and suggestions from one participant to the other. And I think a lot of them have been covered.
Okay.
Everyone liked Javier Amador's work. So if there aren't any other questions, I wanted to sort of wrap up. We are at the end of our time. Thank our speaker for his presentation. It was absolutely excellent. Thank you.
There is one question, Tom.
Oh, is there? Go ahead, Betty.
Veronica Constantine asked, are there natural sources of lithium like foods or water? Is it naturally occurring? It is a naturally occurring mineral. And
It
somebody
is.
answered lamictal.
There is yes, lithium is a salt that occurs naturally. The amount of lithium that can be found in diet is pretty small compared to the doses that we make. There is this supplement now. It's still, you know, I do not have a recommendation for or against, but there's a supplement that's called lithium orotate that seems to be in the market, and it's at low doses of lithium. The thing with lithium is that it really has to be done under the supervision of a doctor because of the concerns for kidney problems and thyroid problems. And there's one study, European study, on there's some societies that have more lithium in water. And in those societies that just there's naturally more lithium in water, they seem to have less suicide in that society. Now, those studies are controversial, but that's some of the, you know, things that how lithium seems to, you know, play a role in our mental health.
Thank you very much. Yes, the last note was just a thank you in the message. With that, I'd like to wrap up our evening tonight. I thank everyone for attending. I thank Dr. Ortiz for putting on a great presentation. I really appreciated the clarity of your information, and I thought the level was just fantastic. So thank you for helping us all, and good luck to you in what you're doing. And we're probably going to try to have you come back next year and speak a little bit about first episode psychosis and some of what you're doing at UNM. So thank you so much.
Anytime. Thank you.